thank you very much for this invitation to talk to you this evening. And essentially, I'm a mucosal immunologist, and we focus specifically on HIV and events in the female genital tract that predispose women to HIV infection or put them at higher risk of transmitting to their partners. And this is just, I didn't know quite what level to pitch it, so I'm going to just start from the very beginning for my own benefit. But obviously, within the female genital tract, in terms of HIV infection, the cervix and the transformation zone specifically is the area putatively most at risk of HIV infection. And this is also the area where most HIV target cells would be found. So these would be the CD4 positive activated T cells and dendritic cells that would be in this region in women. There have been various mechanisms proposed by which HIV crosses the mucosal barrier in the female genital tract, which is incredibly efficient actually at blocking most viral transmission. Basically microabrasions associated with ulcerations or trauma of various sorts, as well as basically dendritic cells sending dendrites into the lumen of the vagina, have been proposed as mechanisms by which HIV can traverse this barrier and gain access to this beautiful pool of activated target cells that are sitting there waiting to take the virus from the site of first infection through to the draining lymph nodes, where obviously the infection spreads. So there are a number of studies, and I don't need to tell this audience, reporting an association between the presence of sexually transmitted infections in the female genital tract and enhanced susceptibility to HIV infection. And a lot of these papers came out more than 10 years ago, and there's quite compelling evidence for the association between STIs and HIV infection. And the mechanism by which sexually transmitted infections, well, one of the mechanisms by which it's been proposed to enhance HIV risk is genital tract inflammation associated with STIs. This inflammation obviously is associated with recruitment of these activated target cells. So this very crude cartoon just shows the squamous epithelia of the female genital tract, and these are little SIV particles, because the first story I'm going to be talking about is evidence from primates. And this study is now 2 years old, but it was one of the pivotal studies that came out recently showing that inflammation in the genital tract is a necessary step to initiate a productive SIV infection. So in monkeys that did not have genital tract inflammation but were passively exposed to SIV, so there was no sort of trauma associated with infection, they were just SIV put into the genital tracts of these macaques. If they didn't have genital tract inflammation, they didn't have a productive SIV infection that followed. This study in primates showed that dendritic cells and other cells produce this whole cascade of inflammatory cytokines in response to SIV infection. And maybe the names aren't as important other than the fact that this chemokine gradient then calls all these activated target cells. So these are the CD4 positive target cells getting recruited into the genital tract under this inflammatory gradients. And then these would serve as targets for SIV infection. So what I'm going to be taking you through today is work we've been doing with Caprisa 002, and specifically I'm going to just start taking a step back from the tenofovir trial and the findings from the Caprisa 004, but just to look at the acute infection study, which actually had a lot of important signals that played out in the Caprisa 004 trial. And I thought it would be nice just to take that step back and look at the story of inflammation in 3 parts. So the first part is where we focused on women before they became infected with HIV. So this was a cohort of over 200 women enrolled, screened 6 monthly for sexually transmitted infections by laboratory testing, and cervicovaginal lavages taken. And we looked at the role of STIs and genital tract inflammation in the acquisition of HIV infection. Secondly, after the woman became infected with HIV, we looked at the role of genital tract inflammation in disease progression. So did those early events when the women are first exposed to HIV and become infected, did those early events that took place in the genital tract play out in the subsequent rates at which their disease progressed and CD4 decline and viral load set point? And then to end off with a mechanism of breakthrough infections in women who became infected in the tenofovir trial, and specifically the role of genital tract inflammation in those breakthrough infections. The CAPRISA-002 acute infection trial was established in 2000, and I'm sure Lynn Morrison would know much better than me, but in early 2000s, in which 245 HIV uninfected but high-risk women were enrolled into the cohort. They were followed monthly, and each woman was tested and treated for active STIs or bacterial vaginosis at enrollment and 6 monthly. And these specifically were the lab-diagnosed STIs screened for. Chlamydia, gonorrhea, and obviously HSV2 shedding are the important inflammatory STIs. And cervicovaginal lavages were taken, saline, 10 mils of saline, flushing the genital tract under speculum exam at enrollment into the study. And this is work led by Koleka Mlisana, who's now in Johannesburg, but was at CAPRISA at that time. But this is just a breakdown of the Sti demographics in those 245 women. And as you can see from the graph, that over 60% of the women enrolled in the CAPRISA-002 trial had an active STI or BV at enrollment, and 20% of these women had greater than 1 infection, with BV being the most common co-infection in women with active STIs. And basically the yellow bars are women with single infections, and the red are women with dual infections, and most often the dual infections were with bacterial vaginosis. So from the Cape Town laboratory point of view, we looked at inflammatory markers in the cervicovaginal lavages, and we used Luminex multiplex assay to measure 32 different inflammatory, regulatory growth factors and adaptive chemokines and cytokines. And just for the purposes of this talk, obviously we're very interested in inflammation, so a lot of the panel focused on inflammatory mediators, although we did broadly look at other classes of markers to investigate the association between these inflammatory markers and sexually transmitted infections. This graph just shows the beta coefficients of logistic regression. So the reason we did logistic regression was because a lot of the women had dual infections, and we grouped each of these women categorically into distinct categories after controlling for the other co-infections that they had. But the take-home message here is if the size of the bar above the line indicates increased risk or increased inflammatory responses associated with STIs, but the bacterial vaginosis in the specific example showed that some of the cytokines were actually associated with a lower, so bacterial vaginosis in this example was associated with a lower cytokine response for certain classes. So that bacterial vaginosis isn't a completely 100% inflammatory STI. It is associated with downregulation of certain inflammatory cytokines too. But what you will notice from this is that chlamydia is overwhelmingly giving the strongest inflammatory signal. It's also quite commonly asymptomatic, and therefore wouldn't be a woman presenting with asymptomatic chlamydia wouldn't be gaining access to the syndromic management offered in South Africa. Gonorrhea, although the number of gonorrhea in a woman with gonorrhea was quite small, it was also very inflammatory. So basically chlamydia, gonorrhea, and HSV2 in the CAPRISA cohort, as others have reported previously, were associated with quite a substantial upregulation in a lot of the inflammatory molecules that we investigated. So when we stratified the data into the women in the cohort that stayed negative during the whole 2 years of follow-up, compared to those who seroconverted during follow-up, we found that several of the cytokines, and I've just shown them on the right-hand side, were significantly associated with risk of HIV infection. Although the time between the CVLs were obviously taken at enrollment into the study, and women often seroconverted many weeks after enrollment, there was an association, albeit quite a small one, between elevated inflammation in the genital tract at enrollment and women becoming HIV infected. And because STI laboratory diagnosis was done at much more regular intervals in the study, we superimposed our inflammation data onto the STI diagnosis. And if you look at the data in this way, women with less than one STI per visit, so these are the women who didn't have STIs, the rates of seroconversion to HIV was quite low, but compared to red lines being women with one STI per visit or greater than one STI, that there was a significant association between the woman having an STI at any of her study visits and her becoming HIV infected. So this analysis included all active STIs, including chlamydia, gonorrhea, trichomonas, and HSV2. And individually, from this analysis, gonorrhea stood out by far as being the most significantly associated with HIV acquisition, with a hazard ratio of 7.1. So from our perspective, we were quite interested to look at symptomatic versus asymptomatic STIs, because we had clinical symptoms of discharge and vaginosis, and we also had the laboratory diagnosed STIs. And if we've, in this analysis here, we've grouped women either as the grey circles having no STIs, BV or discharge, the light blue having a laboratory diagnosed STI with discharge, and these obviously would be the women that presented at an STI clinic and had access to syndromic management, compared to the dark blue circles, which are women with laboratory diagnosed STIs without discharge. So that would be your asymptomatic group. And just by the number of dots, you can see it's quite a substantial number of women who didn't present with any signs and symptoms of STIs, but had a laboratory diagnosed STI. And the key thing for us is that 7 of the cytokines we measured were significantly higher in the asymptomatic woman compared to the woman with no STIs. And in almost all of the cytokines we measured, there was no observable difference between asymptomatic and symptomatic women when it came to the level of inflammation they presented with in their genital tracts. So what we concluded from this part of the study was that women in communities of high risk of HIV infection have high rates of asymptomatic STIs. Syndromic management alone, as practiced in South Africa, is not adequate in high-risk communities, with only 16% of women being suitably treated using the syndromic approach. Women with asymptomatic STIs had elevated genital tract inflammation, which may place them at greater risk relative to women with no STIs. The second part of the talk is going to focus on the group of women that, and in this analysis, it's 40 women in the Caprisa cohort who became HIV infected. These women were followed relatively intensely, and we had cervicovaginal lavages monthly from enrollment into the acute infection study. And what we were interested in is looking at the genital tract inflammation during acute infection and subsequent HIV disease progression. And markers we used for disease progression were CD4 T cell loss to 12 months of infection and viral load at set point. So the women from this 245 who became infected, 28 came from the Caprisa 002 pre-infection study, and 21 women were enrolled from other cohorts within the Caprisa umbrella, giving a total of 49 HIV-infected women. These are the time points they were followed at post-HIV infection. Lavages were taken relatively intensely during the first year of follow-up, and viral load and CD4 counts were taken at matching time points. And we used the sliding average around 12 months to calculate viral load set point and average CD4 counts. So this is quite a complicated slide with the, we had matching samples, pre-infection samples from a subset of 18 of the women compared to the acute infection time points, which is a really a powerful analysis to do when you have each woman being her own control in this example. And what we did find when we compared these matched time points pre-infection to post-HIV infection was that none of the broad range of cytokines we measured were elevated compared to those women before they became infected. These are the regulatory growth factor and adaptive cytokines we measured, and the open bars are the pre-infection and the closed bars are the post-infection. And these are the inflammatory and innate markers, and we did see some fluctuations in certain cytokines that were weakly significant, but fell away after adjustment for multiple comparison. But some of them, like MCP1, for example, was actually significantly lower after HIV infection. So there wasn't sort of a clear inflammatory storm after HIV infection that we actually went into the study expecting that women during acute HIV infection would present with a much bigger inflammatory cloud compared to their pre-infection time point. And actually, if we've compared these women, acute HIV infection women, to women in the cohort who never seroconverted, and there was a significant difference. So these 18 women, although their own pre-infection samples weren't significantly different from their post-infection samples, they were significantly different from other women in the cohort who did not go on to seroconvert. What was also interesting was that more than half of the cytokines measured correlated between pre and post-HIV infection and at later time points. So this means that women became HIV infected who had a high concentration of inflammatory cytokines before they became infected maintained that level of activation or inflammation after they became infected, and that was sustained over time, compared to women who went into infection having a low inflammatory profile, were also the ones who had the low inflammatory profile after they became infected. And after HIV infection, over 80% of the women during acute HIV infection had a lab-diagnosed STI. And when we stratified our data, our inflammatory data, according to STIs, once again, as we saw in the pre-infection samples, the inflammation we were measuring was not associated with HIV infection per se, but was associated with other active STIs going on in the genital tract of these women. And in this example here, HSV2 shedding was by far the most inflammatory of the STIs we measured, then chlamydia and gonorrhea. So the other thing that was important in the group of women for which pre and post HIV infection samples were available was that the prevalence of each STI did not differ between pre and post HIV infection, suggesting that obviously STIs in the women who went on to become infected were putting them at greater risk of infection, and they were the same women that had the STIs after they became infected. This is a relatively old piece of evidence we published in 2009 from the Caprisa cohort, where we looked at genital tract inflammation, and these are all the participant IDs on the y-axis here, and on the x-axis is on this heat map are the different cytokines we measured, and we've stratified from sort of the bottom of the graph being women, the more intense the red color, the more inflammation they had going on if you ranked them according to sort of the highly inflamed versus the less inflamed. And when we compared the level of inflammation to their CD4 counts during acute HIV infection, so during acute HIV infection they've obviously got quite substantial depletion in their CD4 T cell counts, we found that women with the highest level of inflammation were also the women with the most severe drop in CD4 counts during acute HIV infection. And several of the cytokines, in this example here, 10 cytokines that we measured were associated with CD4 depletion during acute HIV infection. And the adjusted p-values, after adjusting for multiple comparisons, 5 of those remain significantly associated. So having genital tract inflammation at the time around when you become infected is associated with more substantial CD4 decline. So we took this analysis further on. So if we know the CD4 decline was more severe in women with elevated genital tract inflammation, what effect did this have on their subsequent clinical disease progression? And this is following women out to 12 months post-infection. So what I've shown here on the y-axis is each of the cytokines we measured, and on the first set of data is the 6-week cytokine concentration. So that's the earliest time point for which we had lavage samples available. And what you can see here is that GM-CSF, IL-6, IL-10, IL-1 beta, and TNF-alpha were all significantly associated. So it's a negative beta coefficient, which means, if you read the bottom, a 1 log increase in IL-6, in this example up here, is associated with a 0.2 log decrease in CD4 counts at 12 months post-infection. And this was significant after adjusting for multiple comparisons. And that wasn't just at the early time points. In fact, at 17 weeks post-infection, the same cytokines were coming up as being associated with more severe CD4 depletion at 12 months post-infection. When we looked at the other side of the algorithm at viral load set point at 12 months post-infection, which is not as reliable a predictor of disease progression as CD4 counts, what we saw again at the 6-week cytokine concentrations was that several of the common cytokines were associated with a significant increase in viral load set point at 12 months post-infection. And just to sort of break it down into easier units for me to understand, a one log increase in this example of IL-1 beta, which is the second cytokine on the list there, was associated with almost a 1 log increase in viral load set point, which is quite substantial. So our take-home message from this part of the study was that elevated inflammation and T-cell homeostatic cytokines during acute HIV infection consistently correlated with lower blood CD4 counts and higher viral load at set point. So the conclusions from this part of the study were that inflammatory cytokines in the genital tract during early HIV infection were not elevated compared to those same women before they became infected, but rather we found a strong correlation pre and post HIV infection. The data that we had available to us suggests that active STIs were driving increased inflammation in the genital tract. And cytokines in the genital tract during early HIV infection correlated with lower blood CD4 counts at the same time point, lower blood CD4 counts at 12 months post-infection, and higher viral load at set point. And data I haven't shown you today, and we've measured this longitudinally during the first 12 months of follow-up, elevated HIV shedding in genital secretions, putting those women at greater risk of transmitting to their partners. And then to end off with sort of a culmination of what the acute infection study taught us about the role of genital tract inflammation, looking at inflammation in the genital tract and its role in breakthrough infections in women in the tenofovir trial, the Caprisa 004 trial. And obviously, Dave gave an introduction to the 39% protection offered by the 1% tenofovir gel that came out last year. And this just highlights the adjusted incidence in women in the tenofovir arm compared to women in the placebo arm. And this study was a lot bigger than the Caprisa acute infection study, enrolling 889 women in total, in which 445 were in the tenofovir arm and 444 were in the placebo arm. Lavage samples were taken at regular intervals during follow-up, and once the woman, the subset of women seroconverted, they were enrolled into the acute infection study, and lavages were also taken at regular intervals after they became infected. Importantly, one of the first analyses we did was obviously looking at inflammation associated with product use. So what we found consistently in the 12 cytokines we measured was no significantly elevated or absolutely no differences in women in the tenofovir arm compared to the placebo arm in terms of genital tract inflammation. So there's no sort of evidence of a safety issue associated with tenofovir gel use, which was an important primary observation. But what we did find in this analysis here, we took pre-infection lavage samples from women who became infected, so there were 98 HIV infections during the trial, and compared these to women who remained negative in the trial, despite using lots of product and lots of gel. And these were the high gel users. And this is a fold increase in cytokines of women who became infected relative to those who remained negative. And here you can see that 9 cytokines of the 12 we measured were significantly and sometimes almost 10-fold higher in women who became infected compared to those who didn't. And when we did a principal component analysis of this, and it's also like heat maps, so any red color is associated with elevated inflammation, and green, well, actually, green are associated with the down-regulated cytokines. And on the top bar, you can see any little blue square is a woman who later became infected, compared to the yellow boxes, which are women who remain negative. And what I hope you can see is that that big block of red is sitting squarely in women who later became infected, and women with comparatively down-regulated cytokines were all sitting in the domain of women who remained uninfected during the study. So they definitely clustered significantly into whether they became infected or they remained negative. We looked at the odds ratio of these cytokines and the association with susceptibility to HIV infection. And as you can see here, unadjusted, 6 of the cytokines out of 12, so half of the cytokines we measured, were associated with increased risk of HIV infection. When we adjusted for tenofovir gel use, 4 of them remained significant. And in the last box, we adjusted for multiple comparisons, and we also adjusted for contraception use, condom use, and age in that analysis. And the ones that come out as being really important, interestingly, are the MIP1 alpha and beta cytokines, which in the monkey study I started my talk on were the 2 key cytokines associated with recruitment of target cells to the genital tract. So in this context, those exact markers are coming out as being important at putting women at risk of HIV infection. The other thing we found very interesting was that 7 of the 12 cytokines we measured were significantly correlated between time points. So women sustained that level of inflammation over time. If they had higher inflammation at one time point, they maintained that level of inflammation at the next time point. And this analysis included 2 pre-infection time points from the woman who became infected. So it's important to just establish that this wasn't an isolated incidence of elevated inflammation, but these women sort of had a phenotype of elevated inflammation. So the conclusions from this part of the talk was that women in the Caprisa 004 trial who became HIV infected had higher levels of inflammation in the genital tract prior to them becoming infected compared to women who remained negative. And this suggests that high levels of genital tract inflammation may have facilitated breakthrough infections in women using tenofovir gel, and that future trials should include strategies to better control genital tract inflammation, and that the presence of genital tract inflammation makes the bar that, of protection that tenofovir has to reach that much higher. And this is to acknowledge Lindy Roberts and Lenine Liebenberg from my lab. They're both PhD students who are on the verge of submitting their PhDs, who did all of the laboratory cytokine analysis and stats that I've presented. And also to acknowledge the Caprisa 004 team headed by Slim Abdul Karim in Durban, and a lot of very important collaborators that made the trial possible. Thank you.